Hi, good afternoon. This is Vicki Lowe, Executive Director for the American Indian Health Commission. We did have quite a few people registered, and I'm not sure about the impact of the tribal leaders meeting with the governor at 1:30 on attendance today. So if you all don't mind, maybe we can wait a couple more minutes and see a few more people log in, and then we'll get going. So thank you for joining us, and thanks for your patience. Okay, I don't really see people logging in anymore, so I think we can get started. Thank you for joining us. This is, as I said, my name is Vicki Lowe. I'm the Executive Director of the American Indian Health Commission. And we want to share with you the managed care organization performance measures that we developed over last summer, the summer 2019. Talk about the plans for implementing them and some other managed care issues we're having. So I have with me today Heather Erb and Lou Schmitz. Heather, do you want to introduce yourself?
Sure. Good afternoon, everyone. My name is Heather Erb. I am the legal consultant with the American Indian Health Commission. Glad you guys are here today. Thank you.
And Lou, are you going to show your face?
My name is Lou Schmitz, and I am one of the members of the team of consultants for the American Indian Health Commission. We're glad you joined us this afternoon.
Thank you. Thanks for joining us. I think if you go to the next slide, we've been doing land acknowledgements at every session, so you may have already heard me say this today, but I think it's really important to remind us of the history of our land and why we are where we are today. So I would like to begin by acknowledging that as we gather today, we are all on the ancestral homelands of Indigenous people who have lived on these lands from time immemorial. Please join me expressing our deepest gratitude and respect for our Indigenous neighbors. Where I live, that is the S'Klalams and other Salish people. We thank them for their enduring stewardship and protection of our shared lands and waterways. New S'Klallam, which I tried to spell out phonetically, is how you say S'Klallam in our traditional language, and the S'Klalams are the strong people. Thank you. So, as I said, through some funding from the Healthcare Authority, and you can go to the next slide, I think, Lou, in connection with the Governor's Indian Health Advisory Council and the language in the Washington Indian Health Improvement Act, we put in place some oversight of the managed care entities and other non-governmental entities that are interacting with tribes. And so this work was funded under, in part with that body of work. So Heather, I think I will pass it off to you.
All right, thank you, Vicki. Yes, so I think one of the challenges that we had was really taking all of the input that we've had and important contributions from tribal leaders, from Indian Health Program directors, in giving us what was missing in the state system, or what has been problematic. And also piecing together their requirements in the state system that protect Indian healthcare providers and American Indians, Alaska Natives, and also in the federal, and making sure we have that all in one place. And so there was a the steps kind of evolved, didn't they, Vicki? This looks like we sort of formulated this ahead of time, but this is kind of how the process that happened. So really looking at all those state and federal requirements, making sure that they're in state contracts with managed care organizations, and then from that developing the team at the commission developing performance standards for managed care organizations to meet those, and how are they performing in meeting those provisions, and again those provisions that protect American Indians, Alaska Natives, and Indian healthcare providers, and then what kind of monitoring process would be in place. And so Lou will talk a little bit more about that. But in the next slide, we have just sort of an overview about some of the issues that we're talking about that really, again, the tribal leaders and urban Indian healthcare program directors talked about. Sort of these were ongoing themes and patterns that we were seeing. And part of the problem is, while some of these protections have been in state contracts with managed care organizations, the way that they were in the contracts themselves was problematic. And one of the reasons is that there was a tribal section in the managed care contract with the state. And so it's here's a section, here's how you must deal with the tribes. As opposed to when you have a contract between the state and the managed care organization, and there's different subheadings, right? It might be something about network adequacy, or payment for services to providers. And, there are specific rules, federal requirements, for instance, on payment to Indian healthcare providers, but that wasn't in that particular section in the contract. It was just carved out in this tribal section, and we thought that was a problem. And then also there'd be a statement about network adequacy and tribes in one section of the state contract, and then somewhere else, and maybe the language would conflict or wouldn't be clear. So we just wanted to go through the state MCO contract, the latest version. This was, I guess, a couple years ago, and really see if there was anything missing, because there have been recent protections added in the federal regulations, making sure that those were in there, the Indian healthcare provider addendum, and then other ongoing issues, for instance, maintenance of the American Indian Alaska Native medical home. And Vicki, did you want to speak to that particular one?
It is my pet peeve. So with the implementation of managed care across the state, and then kind of what we call the abandonment of the fee-for-service system, we really have found that there was a lack of education on behalf of the providers across the state on what was going on with the fee-for-service system. So many times when we refer our tribal members out from the tribal clinic, they get scooped up into managed care, even if they are already in managed care, and especially if they're still in the fee-for-service system. Some of the major hospitals have hired navigators that don't understand the Indian healthcare delivery system, and they would mistakenly think that a person who was in fee-for-service didn't have coverage and needed to be put into managed care. And what that would do would place them on a different track for coverage where they were separated from the Indian healthcare provider as their medical home, and then they would be with whatever the hospital providers were, and information would not go back and forth. And we heard a lot of complaints about this. It has especially happened in the behavioral health system, and we refer to it as poaching, where they just get poached up out and put in another system, and the person that it happens to doesn't even understand what really happened to them. So that was something we really wanted to address.
Yeah, so that's just one example of many issues that were addressed in the Commission's revisions to the state MCO contract. And really, this was the important first step in the whole process of formally evaluating how MCOs are doing in Indian country. Because of course, we know anecdotally how MCOs have been doing in Indian country. And there has been also a report, a 2013 report to the legislature about managed care in Indian country and some of the problems. But really, we needed to develop, an understanding of what those requirements were of MCOs, and to be able to utilize that as a way to evaluate how MCOs were performing in Indian country. And so I think, so network adequacy is certainly an issue, which gets complicated. And then restriction, making sure that there's not restriction on American Indian Alaska Native enrollment in managed care, preserving and protecting that encounter rate. So that would be the main issue under payment for services. Making sure that MCOs are not requiring contracts of Indian healthcare providers as prohibited by federal law and regulation. And also authorization of services, which still today kind of comes up as an issue, and I'm sure Vicki will talk about that. MCO training of their staff is something that was brought up a lot during the 1115 waiver too, when we were developing standard terms and conditions with the state, making sure that staff is competent to serve American Indians, Alaska Natives is one of the things that comes up quite a bit. And then, of course, crisis coordination and engagement with the Indian healthcare provider, which again, we will get into more details as to what happened in the survey. Does anyone have any questions before we move forward? That was just to give you guys a broad, high overview. And of course, you can ask questions throughout this presentation. And we encourage everyone to do that, especially because we have kind of a small group today.
There we go. No, Heather, Vicki, thank you. This is Jason. And just to sort of support the effort here generally, and I Colette Jones is on as well, our sort of chief nurse here who leads up our quality efforts and can talk a little bit more specifically as you get into more detail here today. But I would just mention too, we're still in a bit of an experimental stage, and some of this may not work. And if they don't work, what are other options? So we also explored, such as Navajo Nation, looking at a tribal-based, owned and operated managed care entity, or like we're doing with the foster care contract today, where we have one managed care plan doing it for purposes of a better focus. Now, not to say, the complexities and financing to do any of that, so may be hard. So I'm not jumping to those conclusions, but I'm suggesting that, we may fail at this. This may not work as designed as well as we'd like. I hope it does, and I hope our metrics are good and show performance, but I also want to be real about this, that we may not have the system in place today to perform as well as we'd like, so we may need to look at other options too. So I think it's good we are starting here to explore this because this is the low-hanging fruit. If this doesn't work, then we need to explore some of the tougher issues and options. But I think we just need to go into this all on the same page along those lines, so there's no surprises, that we're working together on this. And that's our mission, to working with you all, and it's important to us that we get this right in the end. So it'll be I think I've been a little experimental stage here for a while, and I hate to do that, but that's healthcare in our life right now, isn't it?
Yes, thank you, Jason. And I appreciate the fact that the Healthcare Authority has really come to the table with the idea that the answer is not just no, that we do have to figure this out and make it work. And it's, and
Absolutely.
that's very much appreciated.
And I was just going to add to with what Jason shared too, that with these particular items up on the screen, the commission did try to be careful about these were sort of these are the bare minimum, right? Because this is what's required under 90% of this anyway. I think some other things that have been added in consultation with the state, but what's required by federal law. So when the commission submitted a red line, so to speak, of the state MCO contract, we were careful to cite to whatever federal regulation or state in some circumstances required that particular provision. And so we submitted that a couple years ago. I think has it been a couple years? Maybe I'm adding on too much time. I think
we started kind of a couple of years ago. Yeah, okay. Heather, I think that's about right. I think we just implemented this in January.
Okay.
Of 2020. Yeah. Yep.
Yes. Yeah. So there's been a lot of work going back and forth between so many different partners, including the state, and in drafting stronger language. And so that has been a good partnership.
It really has been. Really good effort. I agree. And thank you for your effort. Heather, I don't know what we would have done without your sort of and leadership to push some of this forward. I mean, some of this is like, oh my, that we should have been on top of this from the beginning. So those were, I would say, easy, necessary changes. Some of them are tougher, and that's what I was sort of alluding to earlier. I'm not sure we're going to get there to the satisfaction of some of the tribal clinics and partners in that regard. And so I just want to be open to thinking about other solutions, but focused on trying our best to improve the system and make this work to the extent possible.
Oh, I think you're on mute, Vicki.
Yeah, okay. I'm still not comfortable with you mute, unmute, apparently. Thank you, Jason. Yeah, I think we're very creative, so I think we'll get there.
Absolutely.
Just persevere. Any other comments?
This is just Jesse. Yeah, I completely agree with Jason. And, last December, almost a year ago, we had that presentation at the Governor's Indian Health Advisory Council with some other options, including a tribal managed care entity that is under the control of one or more tribes, including a three-party agreement where the tribe, the state, and the MCO are all parties to the agreement, one agreement, and the responsibilities are allocated in that agreement. So there are some other options. We just ended up going down this route this year. And so those other options are still available. And in fact, we are exploring ways of at least doing a pilot for a tribal managed care entity, but it wouldn't be statewide. So
I think if there's a way not to call it managed care, it might go further. Sorry.
Just using the federal terms.
I know.
Well, we could kind of whatever, market it however we'd like, Vicki, right?
Yeah. All right.
Hi there, this is June.
Hi, June.
Hi, Vicki. Hello, everybody. You know, you're bringing up the, if we could call it something other than managed care. Through this process, I've been thinking a lot about language, and I've been thinking about definition of terms, such as medical necessity. And in my conversations with MCOs, one of the difficulties when in my several conversations with different ones is an understanding of medical necessity and an understanding of our process for determining medical necessity. And sometimes in those conversations, what that means to the MCO is that the request is a waiver of medical necessity. And of course it isn't. And so there's just a lack of adequate understanding of what those might mean in Indian country. And at that meeting, I think it was the one last December when we were looking at terms, and one of the terms was, I think it was cultural humility. And I, of course, I'm an old woman now, and so I'd been through cultural sensitivity and one like that. So we went to cultural competence, and then we asked ourselves, how could we possibly expect that? And now we're at cultural humility. And when that was on the board and being discussed, I thought, who is going to measure that? Who is going to measure whether cultural humility is actually present? And so I asked myself, what would that mean? You know, what would that mean to me? And, you know, I could talk a little bit about that. I won't. But what I can say is that in my discussions with MCOs around the terms of medical necessity and our operation, I think there has been a lack of cultural humility.
Thank you, June. I think that is a real pain point for all of us, is really understanding. And, you know, we are dealing with, and maybe I'm jumping into this way early because this is a slide later, we're really dealing with institutional racism. And it's really hard to weed it out, because just because an institution is racist doesn't mean that the people who are working there are racist. It just means that they're, you know, pretty steeped in how they do things. And so we're trying to do things in a way that 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 neutralizes that racism, and it's painful. So, and, you know, looking at the contract language, and you kind of think, what does that have to do with racism? But it does. We're trying to root out the pieces that really are requiring Indian healthcare providers to work harder and make things easier for everybody else. You know, we shouldn't be asking the Indian healthcare providers to do extra authorizations in order to make it easier for the managed care organizations or the healthcare authority. We should all be, you know, on even keel for that, if that makes sense. So let's go through some of the, I think there's one more slide and then the performance standards. Is that, and so we can kind of talk about those. So, and remember what I said about the institutional racism, which makes everybody's face scrunch a little bit. It really is, and that's part of the reasons this is painful, but it's so very important that we really address this in a way that can be seen by everybody as black and white. You know, here's the numbers, here's what's equal. Right, Heather? Yeah. So do you want to, I can't remember, is this my slide or Lou's?
I can jump in if you like.
Okay.
So as Heather and Vicki have said, where we have been is that we've got the federal and the state requirements, and we have the contractual obligations, but we haven't had a way for tribes and managed care organizations and the state to all objectively see to what extent the managed care organizations are meeting these requirements. There's no way for everyone to kind of be looking at the same information and have some metrics to come to agreement around. And what we wanted was to try to pull together a system that would make it easier to document accountability and compliance for the managed care organizations. Again, coming from a place of, research, people will perform those tasks where they're being measured, where they're being counted. And so really by having some metrics and some shared language that we can all come together and get a good idea for how things are going. And another way to think of it is kind of a report card, trying to have a regular, ongoing system to come up with a score or a report card for each of the managed care organizations. And hopefully have this make it easier for the MCOs to understand which are the performance areas that they need to work on. And what we did was we tried to identify some metrics that would be tied to the requirements. So the standards refer to the corresponding state or federal requirements and or the contract provisions. We tried to kind of define what it means to have compliance, or if you want to think of it as a passing grade, to come up with, again, some metrics that we can all kind of look at them and have some agreement as to what they mean and what they're measuring. And then come up with a process where we can keep up on this on a regular basis so that, time doesn't pass where these performance expectations are not being met, and we really don't get to it for a year or for several years. So we had the primary areas that that Heather reviewed at the very beginning. And what we did was we wanted to get kind of a baseline measure for how things were going, because as Heather and Vicki mentioned, we've got quite a bit of anecdotal information that we've heard from the different tribes and Indian healthcare providers and other facilities that things are not going well in this area or that area, but we had not had a chance to measure it really. So last May, we did pull together an effort to develop an instrument to try to measure some of these areas of performance. We created a voluntary work group, and the small work group had representatives from 5 tribes and both urban Indian health programs. We met 4 times to come up with some questions for this baseline assessment. And we developed an online tool to gather this information. We had 11 of the 29 tribes and both of the urbans complete the assessment, and we really had a very limited time to get this done, and yet we still got pretty good response. So we felt pretty good about the response that we got. So again, some of the areas that stood out as areas needing improvement were the area of access to care and provider network. There was a lot of feedback about how prior authorization causes delays to care, and there's a lack of access to culturally competent care. And so consequently, several of the tribes and the urban said that they had to expend their own funds to provide care that was denied or delayed. Care coordination was also one of the main areas that showed a need for improvement. A lot of the respondents said that the their managed care organization had never met with them. Many of them have not been meeting once a year, and there's been a lack of coordination with the Indian healthcare provider when the Indian healthcare provider patients are being discharged from inpatient care. And there's really little to no coordination on the outpatient care. In the area of contracting, all of the respondents who had ended their contracts with managed care organizations attributed it to the lack of cultural competency in case management services and lack of coordination between the non-Indian healthcare provider services and the Indian healthcare provider services. And their respondents had quite a few reasons for not entering into contracts. The three that were most commonly referred to were that the staff at the managed care organizations don't really understand the issues that are specific to the Indian healthcare delivery system and the benefits and legal protections that apply to American Indians and Alaska Natives. They really don't see a clear benefit from contracting with the managed care organization. And then some of them did note that in order to sign a contract with a managed care organization, they would have had to provide behavioral health services to non-Native clients, and these particular Indian healthcare providers that noted this said that they didn't have the capacity to do that. And another of the areas that was significant was engagement with the Indian healthcare provider. Many of the MCOs had not provided a specific contact within the MCO for communicating and for service coordination with the Indian healthcare provider. Some of the MCOs had not offered timely and competent assistance when the Indian healthcare provider had needed it. Again, the lack of understanding of the Indian healthcare delivery system and the benefits and legal protections. Almost all of the respondents said that the managed care organizations had not included them in developing policies and processes for coordination of care and services. And also, most of them indicated that they had not seen a process for the Indian healthcare provider to have input on how the managed care organization could serve them better. And we have a question from Jesse Dean. Is this data for both MCOs and behavioral health organizations? Yes, Jesse. So let's see if Vicky is available. Vicky?
Yeah, oops. Sorry, I am available and still having my multiple clicking problem. There we go. Hi. So So that was well over a year ago, and you know, a lot's happened since we did the survey and recommended the measures, and it has been a year, more than a year. So we asked for some roundtables and consultations to kind of review the performance measures and talk about how we're going to implement them. And we think, you know, I think a lot of work has been done in the last year and a half on behalf of the MCOs. There have been changes. The BHOs don't exist anymore. Now there's BHASOs, and the MCOs are working on the behavioral health work. So I think it would be good, you know, to move forward with putting in the performance measures and really seeing what improvements have been made. So here are the list of, oh, I did it backwards, of roundtable and consultation meetings we have upcoming about this topic, and then issues that we're having with authorizations. And I just want to say that we've done the presentation of the performance measures with CMS subcommittee, managed care subcommittee, and then a larger committee, and they've asked us to do it again. So CMS is really looking to Washington State to see what we can do to resolve these issues, because we're out there trying to make things work, I think, and we're kind of on the cutting edge of that. So I'm excited for what, you know, is going to come out of these roundtables and consultation. And I think, you know, how we can figure out to, you know, so we have two different parallel systems, and we're trying to like smash them together and make them work together. And so how are we going to actually make that work so that everybody gets what they need, and that it's not more inhibitive for one group than the other groups, I guess is what I would say. So next slide, Lou.
Vicki, I wonder if on the the roundtable sessions slide, if it's worth just talking a little bit more about that, in the sense there is the particular residential treatment service issue that we need to discuss and resolve, right? In terms of, I know June's favorite word, but the medical necessity, finding a solution, hopefully creative solution for that. And so that's what I thought we were doing in those sessions. Are you thinking that those should also include broader topics such as the either report card or other issues as well?
Well, the performance measures and the report card will help us get to some of that. And then here on this slide, I have kind of those issues that the residential treatment facilities have really been feeling since January, but I think they didn't really find out about it until a few months into getting paid from the managed care organizations. So in my mind, it all goes together. I know that sometimes when we have consultation, we've been held to one topic, which doesn't work well for how we view things. You know, when I think of stuff, I can think about how it's all connected, so it's hard to talk in a silo about it. So in my mind, these are related. Jason, I guess is what I'm trying to say.
Vicki, I know, I appreciate that greatly. And just so we're all on the same page, I see it both ways sometimes. We're so in the details at times. So, you know, focusing on one issue, it's hard enough to solve that one issue. But I hear you, and I think I just want to be prepared.
Right.
And particularly, you know, my team and Colette Jones, I think, is on the line. Just want her to be prepared and come in thinking as creatively as possible, as you've suggested earlier. And right, yeah, these issues all connect.
And I think when we first did the survey, and we really, you know, was before the integration and before we really got to the actual act of the MCOs paying tribes the encounter rate. So as that has happened, you know, these are some of the details that have come out that aren't working, that we really want to make sure work. So and these are just from my mind, and June, please pitch in if I'm not quite getting it right. But my understanding is there's considerable question about what constitutes the establishment of medical necessity, and specific to inpatient services, and how can that this be streamlined to honor the assessment of Indian healthcare providers. And that's something, you know, in the tribal centric agreement that we talked about, it was something we had many conversations about through the 1115 and 1915B waivers, about the importance of not having that extra layer of a managed care organization telling an Indian healthcare provider, especially when they're referring to another Indian healthcare provider, what are the metrics they need to meet. And that's part of that what I was talking about, that institutional racism, is that where an MCO might have an expertise in running a managed care organization, but we feel that they've shown pretty regularly that they don't have expertise in providing care to Indian people in a way that an Indian healthcare provider can. So how can we figure out what metrics the MCO needs and make it part of the establishment of the medical necessity that a residential treatment facility does, I believe, before the patient even shows up there, so that we're not doing it every 10 days. I mean, if the treatment is a 45-day plan, which it is for Northwest Indian Treatment Center, and that's part of the care, why are we doing authorizations throughout that time? Why isn't the whole, if that the treatment, part of the treatment is that 45-day stay to get to the trauma and, you know, all the culturally appropriate issues that they're addressing, why are there other authorizations along the way? And what can we do to work together so that the MCOs are getting the information they need, which may or may not be based on NCQA. So there's all these little outlier things that we haven't figured out yet. And how can we address that? And then in the Indian Behavioral Health Act, we codified the definitions of historical trauma and resilience, and how are we incorporating those in the MCO contract. So this is new because the Indian Behavioral Health Act just passed in March of 2020. And then how do we keep the state and the MCO from interfering with that culturally appropriate care, but have them meet their risk management guidelines? Kind of restating the thing I said before. So do those things, I think those are the issues that we're having right now, that even if we put the performance measures in place, we might still have these issues.
So let me add something.
Sure.
It's not that the treatment center objects to medical necessity. We are saying that we establish medical necessity and that we have been in the business of doing that before there were MCOs. And we don't accept everybody. We know what our niche is. We know what we're good at this combination of addiction and trauma. And so we know what level of acuity and what is beyond our reach and what doesn't require what we do. And so a lot of that, because we require so much paperwork to begin with, before someone is approved for admission, we have made that determination. Once we get in, the continued stay problem comes up, because sometimes you actually don't understand the mechanism of the dynamic until you have been with the patient for several weeks. It's not that we don't do an assessment quickly, because of course we do. You know, one of the examples I was using with someone this morning was a child who has been punished by being put between the subflooring and the flooring of a house repeatedly and for long periods of time for punishment, you know, it might take you several weeks to understand that at some point that child never came out from the subflooring. And once well, I won't go into the details, but it's exactly what we're good at, is going and getting that child that is no longer present in the adult and weaving that together into the addiction treatment. And I can explain this to MCOs, and I can give them documents about how we do this and why we do this. And certainly our psychiatrists will tell you that it would be irresponsible to keep a patient under 45 days. So I think there is a way a lot of Indian programs are put together for addressing those issues particular to certain American Indian populations that is our expertise, and we should be the teachers in this area of what medical necessity can mean in the kind of treatment that we do. I hope I've been clear. I find myself hesitant anymore to talk about these things because there's some kind of cross-cultural difficulty in the discussion.
Thank you, June.
Vicki?
Hi, Marilyn.
Hi.
Hi.
I just wanted to add to what June is saying. You know, the terminology that Indian healthcare providers utilize and are very familiar with, and what we have had used before when meeting the requirements with the managed care process before integration in the state. When the state went integrated mental health and substance use disorder treatment, and then integrated the physical and the behavioral health, the tribes had processes that were working with clients that were either exempted from MCOs or participating in MCOs. When we were working with the BHOs, and then when the state changed to the behavioral health ASO process, that's where things went awry, because MCOs are responsible for crisis care coordination, but at the same time, the providers that are contracted with the behavioral health ASO, the service organization, they're following the guidelines that are put in place specifically for behavioral health. And that's where the disconnect has happened. There was not major complications until all of this change has happened. The way the process of getting authorization for mental health and or substance use disorder treatment process that we have in the state now, we never had these complications until the state changed to the integration. And even when the state submitted the plan, the integration plan to CMS, the tribes had submitted comments to CMS of issues that we had problems with the way the state was going to be changing the way of business. And we were assured by CMS that the state submitted responses to the issues that we raised, the tribes raised, but when it comes down to actually implementation now, that's where we have all of these complications. I just can't reiterate this. I understand what June is talking about, and you know, I've been involved with the state and the changes that have happened all these years, but when it comes to implementation, it's the administrators within the MCOs and the state process that there's just not the flexibility to listen and understand where the tribal Indian healthcare providers are coming from. It's not that we're trying to go outside of the process. It's just the terminology is very different, and the guidelines and requirements that they want to hold all providers to, that the Indian healthcare system does not match. I don't know what other way to describe it. So it's very complicated, but it can be very simplified and made clear if we go back to that. You know, we had in the addendum, and we had in the Indian healthcare guidelines, the written protocols that would be followed in order to get services for our people. The mental health and the substance use disorder guidelines we had developed when we were with DSHS, when we were with the Healthcare Authority, and now with our providers being under the DOH, there's just a lot of complications that are just making us not match up with what the state has in place. Thank you.
Thank you, Marilyn. And you do have the long history of being in this this is, you know, a 30-year conversation. So we'd like to get to the completion of it at some point. Was there another comment?
I wanted to add one. Oh, sorry.
Is that June?
Yes, this is June. If I could just, as I've thought about these issues, one I would like to add is that for every $195 per patient day that the state pays to the treatment center, they are getting about $4 more benefit. Not to mention the years long of development of a model that has national recognition. And so there is a way to look at this, that the tribe is, I mean, that the Healthcare Authority is a beneficiary of Indian dollars, I guess is the way to put it. Thank you.
Thank you. Heather, did you have something?
I didn't have anything, sorry.
Okay. Was there someone else that was wanting to speak?
Vicki, this chick,
May I speak?
please.
Somebody, whoever's talking, you're breaking up a little bit. Unless it's just my
It might be your end, Vicki.
Okay, go ahead then. I'll catch the recording.
Again, this is Ashley Hesse. I'm not sure if you're speaking to me. I think Jason or someone else was speaking.
Oh,
Thank you.
no, go ahead, Ashley. Did you have a comment?
I have a few, and I appreciate your conversation, and thank you for pulling it together. So I had a chance to meet with our Surgeon General last week when he was here in town. And one of the most interesting things he said in this meeting, very small gathering, and it was unprompted, mind you, is how much he appreciated working with tribal nations across the country and what he believed is happening in Indian country through our providers is a model of care that's being developed, which the rest of the nation's health system should mirror. So I encourage this conversation and the pushing of the limits of what is accepted and how we continue to provide care in a way that we understand is best suited for our people. And just say that there are people that understand this and recognize it. So I thought that was important. I wanted to share. Now, CMS, of course, they're looking to Washington to take a lead, and this is my opinion and observation over watching this happen in several other states when you try to merge systems and engage MCOs and the states, abdicating themselves of certain responsibilities, in my opinion, but this is how it goes. So you do need to continue to push the limits because there is no one-size solution. CMS is looking for the state tribal experiment to play out in as many different ways, as many fronts as possible to develop options that others can replicate, as I do with any federal rules and shifts in the system and payment structures and how care is provided. So again, continuing to push the limits and experiment here and finding solutions is very important. I'm very encouraged here. Jesse alluded to possibly doing a pilot around a tribal MCO or some such managed care model of sorts. I will say one of the things that I'm not hearing enough in these conversations, and this is just my experience and what I come to for an advocate of individuals, we're alluding to it, but I don't see enough of measuring personal experiences through all of this with both network or non-network providers. I mean, I get I may be missing something, but like, where is the access to these member rights? Who's going to support our tribal members and they engage in these systems versus every tribal, everybody doing their best to support members to in any way you can. There could be really a tribal ombudsman program is what I would say, specific to dealing with managed care, a centralized and supportive structure for member rights, access to state fair hearings and support within that, like member representation and really looking at their outcomes through all of this, I think would be an important thing to perhaps look at when we're starting to look at developing measurements. And that's really kind of, I'll stop at this, but I do thank you for the conversation, for listening for the moment. Thank you.
Thank you, and thank you for your perspective and pulling it back away to the the higher level view. And a lot of times when we get down into the weeds, we really forget the intent of why Indian people are using the Medicaid program, and it is to meet the federal trust responsibility, and it is the federal government kind of passing that on to the states, who in turn have now passed it on down to the MCOs, whether we don't have that government to government relationship. And I think that's definitely part of the problem. And it's important that we do have these conversations, and I'm glad to see the people who are here. We will continue this conversation. Lou, can you go back to the slide before this? And so again, we will be having those conversations here. And I think a couple things, I don't want to put you guys on the spot, but actually I like doing that, let's not lie. Jason and Jesse, a couple things we are looking for these roundtables are really to understand what is the, and maybe the MCOs can help with this, what is the risk management or the NCQA issues that are keeping them from the authorization of the from just honoring the medical necessity established by the residential treatment facilities, as well as any other Indian healthcare provider. I mean, if we're having that here with this, is it going to pop up somewhere else in another type of authorization if we don't deal with it here? And that, I think those were the main things, just kind of where the federal agencies conflict with each other. I know we have a lot of that with IHS and like Medicare rules, but now we're seeing it with just within CMS with the Medicaid rules, and then the Indian Health Services, how care is provided at an Indian health facility. So I'm hoping we can have a conversation about that and really get to not why stuff can't be done. And I know you guys don't operate that way, but really thinking about how we can make this work so that all the boxes are checked for everybody and that there aren't access barriers to appropriate care for Indian people.
Absolutely, Vicki. From my perspective, absolutely. Let's, I think we'll have Colette as our just guru expert on all the CMS requirements. Yeah, so we could certainly dedicate some time going into that level of detail. I think from my perspective too, Vicki, in terms of federal to state to MCO delegation or authority, however you want to call it, you know, I hear you, but the state is not delegating any of the state's authority to MCOs. We can't do that. So for at least from my point of view, it's our job from the healthcare authority, you know, working with Jesse, who's just such a great guidance on these issues, but it's our job to hold up our side of the treaty rights and so forth. So I think it's important just to say that, even though clearly in operations, it's seemingly MCOs are causing some consternation at this point, but it's our job to try to resolve that. And then if I may just say just my thanks and honor Marilyn in June. June, you know, I'm not sure we've actually met. I look forward to meeting you one day. Your wisdom and knowledge here, you know, I've been listening to you today and look forward to learning more from your perspective. I couldn't agree with you more. And we do have to come into this thinking from a sort of a humble point of view, because we don't know. And we have to listen and be creative and think through these problems. And I think we're going to do that and do all we can to do that. And it may be difficult in these changes, but hopefully we can get there. And Marilyn, you know, anything you say, I'm all ears and listening. You're such a wealth of knowledge, and appreciate your wisdom and collaboration through all these issues, all these years. Thank you again.
This is Colette Jones, if I may jump into the conversation.
Yes, please. Thank you.
Thank you. Just to introduce myself, as I'm fairly new to this group, I am a nurse, as Jason mentioned, on his team, and I oversee the compliance of the managed care plans to make sure that the programs are running the way that our state is expecting them to do. So overseeing those contracts, especially around clinical areas. So I just want to appreciate the conversation today. There's been really open conversation, and we very much appreciate hearing your perspective on what is working and what's not. There are very complicated systems and very complex expectations that we expect from our managed care plans, and figuring out the challenges in there take a lot of time and attention and discussion, just like this. And I know that you folks have been talking about these issues for a long time now, and I greatly appreciate being a part of them, because it helps me understand that the challenges that you are seeing on a day-to-day basis are impacting clients' care, and that is definitely not what we want to see. We want to partner with you to help understand how we can reduce those barriers. Another thing that I would say is having specificity in that feedback is incredibly helpful to us. So as an example, I've heard a lot of large concerns here today that I don't want to dismiss, but I want to know more about. The overarching concerns are very helpful to understand, but difficult to pin down from a compliance standpoint on how to change that. I think it was June that said she reflected earlier on cultural humility and what that would mean to see whether someone is or is not applying that appropriately. That kind of conversation really resonates with me, as I want to get to the nuts and bolts and figure out how we can agree or disagree that something is working the way we want it to. So having those really detailed conversations helps us know how to move the program forward. For example, the conversation that's in front of us about what does a managed care plan need to know about this program. I wrote it down because I knew I wouldn't remember the name, I'm sorry, Northwest Indian Treatment Center. I think that's very helpful to know that level of specificity about that particular issue, that review, the prior authorization that needs to be reviewed routinely, and what is it, the barriers, what is it that a managed care plan would need to see from that provider to better understand what medical necessity would look like. So that kind of specificity in a question is really helpful to us so that we can really dive into those details and figure it out. I'll stop there, but just appreciate this conversation.
Thank you, Colette. It's good to hear from you and nice to meet you.
Thank you, too.
We hope to be spending more time with you in the next months.
Yes, I agree.
Vicki,
Yes, Marilyn.
I think one of the things that, and I mentioned earlier that I think one of the issues that we have is just a difference of terminology. And one of the things that came to my mind that I know that the state has utilized trauma-informed care. You know, that's a service that is understood and clearly defined. You know, that's comparative to what we're talking about with regards to cultural humility and the need to, you know, recognize the level of treatment that an individual may need. And many times, many of our people have, you know, not received the level of care that they had needed for many years. And it may take, you know, 15 days, the first 15 days of the 45-day treatment program to just get the surface, the beginning level. And so I think that, you know, I mentioned that the terminology, that's kind of, I think, the focus that we need to have our providers be on the same page with the terminology that meets the requirements in order to, so that our providers will be able to submit the documentation that is needed to get the authorization for the level of treatment required. Thank you.
Thank you, Marilyn. You do make a very good point about the language and what, you know, authorization, referral, and all those, you know, culturally appropriate care, trauma, all those things might mean something different to an Indian healthcare provider than they mean to a managed care organization. And we do need to get it figured out because we should all be on the same page. Otherwise, we're just creating access barriers for people and not really doing our jobs. Thank you.
Vicki,
For what it's worth, Vicki,
Oops.
Marilyn, I agree with that, and look forward to ways we can do it. And again, Vicki, for me, it's not really what the managed care plans think as much as it is what our CMS rules and our SPA, the state plan amendment, which we operate under. And so we have to look at sort of the legalities of that, and then Colette and team think creatively about how we get this built. So that's my hope, and through further conversations and discussions, I hope to get there on this issue. And I think you raise another good point in the sense of what's the next issue, or are there other issues out there? And I suspect there may be. This will give us good, I think, guidance and tools to help resolve that, and sort of the resiliency that for us all to be prepared to do that, I think is probably in order as well.
Yes, thank you. And I think June, you had a comment?
Yes, thank you, Vicki. Thank you, Jason, for saying that. I don't think it's a matter of what the MCOs need from us, but that we could inform the MCOs of how it is that we determine medical necessity and how we go about that process. Because in truth, we will train an intake coordinator working together with the nurse, and we will train them for a year before they're actually adequate to even do these initial reviews of what's coming in, to make sure that we don't get a level of acuity that is inappropriate for us, and to make sure that, well, there's just all sorts of parameters that we look at. And certainly we could provide a document to that that would describe what those parameters are. And they are medical necessity in terms of looking at trauma in the company of addiction, but they're complex. So I think we could work together to develop something that would be useful to the healthcare authority.
Thanks again, June. I couldn't agree with you more, so I look forward to that.
This is Colette again. One thing that may be helpful in this conversation is understanding, bringing the contractual language to this conversation to then match it up with how these terms are discussed and considered and what the expectations are here in the room. I think what I'm hearing is there is a difference in terminology. There is a difference in expectations in how this comes together. And I think we are both saying the same, apple and apple, but it may not be gelling in the way we expect. I don't think apples gel, but my point is, I think it would be helpful to have more conversation around what terminology and expectations that this group is bringing, and also how that's communicated from the state to the plans, and make sure that those align.
All right, so thank you. This is Vicki. I'm just wondering if maybe Heather and Lou and I could do like a presentation on the performance standards and our recommendations for the changes, and really kind of talk those through as preparation for the roundtables and consultation, because I think it'd be really helpful for you to have that understanding as we go into those meetings.
And,
I
Vicki,
would
this
love
is
that.
Heather. I was just wondering if Colette, hi Colette, this is Heather. I was just wondering if you had received a copy of the, I don't know how many pages it is. I think it's probably about 7 or 8 pages of the edits that the commission did to the MCO contract.
Yes, I did. That was
You did, okay.
earlier this year, correct?
Yeah.
Maybe late 2019.
No, it would have been an older document. So we did do a letter referencing our edits, but I don't, well, maybe we did attach the actual edits. I guess I'd have to look at it and just make sure you had the same.
Maybe it would be beneficial to, I'll loop back around with Jesse. I'm sure he and his team have all those documents, and I'll make sure that I have all of that in hand.
Okay, sounds good.
Thanks, Heather.
And I do believe they're on our website, though we've been doing some upgrades to our website, so I'm not sure the exact location. Lou, do you want me to find it real quick?
Yeah, hold on, I can click over there.
And Lou, while you're doing that, the other question I had is, were you thinking of renewing that survey, doing that survey again as part of the sort of the effort here to review how we're doing? Or?
Well, we were, the idea was that we would implement the ongoing system, so that there would be tracking, monitoring year round, and then once a year we would do kind of a feedback type of assessment where the tribes and the urbans complete it. We would probably adjust it a little bit, make some changes to the current instrument. But yes, the idea was to have the ongoing system where those metrics are tracked throughout the year. And then in addition to that, once a year have a more focused feedback opportunity for tribes and urbans.
Lower on the page here.
No.
Oh wait, provider evaluation right there. Click on that the big letters. Higher, right under the time. There.
Yeah, this, let's see what, I'm looking for the,
Okay, well, we'll find it and get it out there. So any other questions or comments?
Maybe Paulette, wonder if it might be, oh, I'm getting some background.
Somebody watching Star Wars?
Yeah.
so this has all of the documents here, Vicki.
Okay. Can you put that in the chat box, or we can email it out too?
And Jason, again, I couldn't hear you on that last comment. I'm sorry if you were asking me to speak to something.
Yeah, I was just going to note that along the same lines of sort of Lou's work here with the survey and some follow-up, that might be good, Colette, to collaborate on, because Colette, her team does a lot of the quality review to ensure that the plans are meeting certain contract requirements. We call it our team monitoring program. And maybe there's a good collaboration there that we could work on, sort of vis-a-vis that sort of report card idea. So Colette, not sure if you have other thoughts on that, but just a
Yes,
thought.
thanks, Jason. That resonates with me as well. And I think I'll brainstorm on that in the meantime and see what we can do to move that forward a bit. And I'll reach out to Jesse and team if I need more of this background information to help support us.
And this is Jesse. Colette and Jason, I just sent you an email with this link that that Lou helped us find on the AIHC website.
Thanks, Steve.
Great.
And again, remember the survey was done kind of at the end of the life of the BHOs. And hopefully, once we can get the performance measures in place, we can see some improvements.
Right. Good. Well,
All right.
I feel, you know, Vicki, for what it's worth, for June's, your background, I feel much more sort of prepared for a good conversation and solution oriented on at least this sort of the residential issue. I'm sorry, what I'm calling the residential, the treatment center.
Mm-hmm.
And at least there's that. I feel like we've got a good start on a conversation with regard to follow up. Again, this report card idea, that might be good for conversation. And then I think the future looking, like what can we learn from what our conversations are here with regard to coverage decisions, and again, I'll use the term the CMS gave us, the medical necessity, but apply it differently perhaps than what we would normally do in other cases, or just think of different opportunities along those lines to account for the differences in the systems and the people served. So I think we could get there. I think it may take some creativity, and it may be difficult in the sense of working with CMS and figuring out solutions that work for them too. So I don't want to be a sort of a downer on that, but I do want to be realistic going into it. So I think this has been very helpful to get us oriented in that regard. Thank you again.
And you work with different people at CMS than we do. So, I mean, CMS Tribal Affairs is very supportive of this, but I do understand that, and I think we can get there with what the residential treatment facilities are already doing for medical necessity, and really kind of looking at, but thinking of it through the lens of really providing culturally appropriate care and addressing trauma. And these are things that I think maybe you said it earlier, Jason, are lessons that could be taken into the rest of medicine, into behavioral health services, in other places. So I think we're kind of on the cutting edge here, but that's where we like to be in Washington.
That's right.
I think if you think about the Northwest Indian Treatment Center, it's a very sophisticated program, you know, where there's tiny little place on 2.5 acres in Elma, but the model is very sophisticated. The fact that we are paid at a residential rate doesn't negate who we actually are. And I like what Marilyn said, is that a lot of the American Indian programs don't fit all of the categories really well, because the categories are somewhat simplistic in their definition. And we've been integrating behavioral health for some time.
Yes, thank you, June. Any other comments before we wrap up? Okay, so thank you all for joining us. I know there's so many other things going on today, so we appreciate those of you who are able to join us. Here's where those documents are on our website. If you go to, I think it was Indian Healthcare Delivery Systems, it's down below there. And then also, if you go on our website and go to meetings and events, you can see the tribal, or not the tribal, yeah, the summit webpage, and you can go there. There'll be recordings and all the handouts from the different breakout sessions can be found there if you missed anything and wanted to catch up. I think my voice is already giving out on me, and I got one more of these to do. Any other thoughts or comments?
– Thank you, Vicki.
Thank you all for joining us. Ed has a question. I can't see Ed's question. Blue.
It says, it's a comment from Ed Fox. It says, got here a bit late, but sounds productive. Thank you, Ed.
All right. So thank you, everyone. Enjoy the rest of your day. Maybe we'll hear some of you in the tribal food sovereignty breakout that's next, or I'm sure we'll be seeing you tomorrow on our closing, and we'll have the health breakout session as part of our closing meeting for the summit, and then we'll have Centennial Accord. Busy week. Everybody hang in there. Have a great day.
Thank you, Vicki. Thanks for the commission's leadership and organization. Appreciate it.
Thank you. Thanks, everybody. Have a great day.